Well, welcome everybody, and good afternoon. I'm Mark Pauley. I'm the co-director of the Interdisciplinary Nursing Quality Research Initiative, better known as INQRI. And on behalf of the management team, Mary Naylor, Lori Melikar, and Heather Kelly, I'd like to welcome you to the second in our series of webinars on dissemination and implementation of evidence-based practices. A little bit of the history of INQRI for people who don't know its glorious history. It has been funded by the Robert Wood Johnson Foundation, and we want to thank them for their support over the years for our program and our grantees. The program has gone through several phases. The first phase, 4 years of grants that funded new research ideas that would demonstrate the link between nursing and the quality of patient care. Then the second phase, which is relevant for today's webinar, was a result of our final grant solicitation in 2010, where we sought to build on the research conducted in the first 4 years by not identifying new topic areas so much as addressing another core dimension of INQRI's mission, the translation of knowledge to improve nursing care and patient outcomes when the knowledge was already there. So in this final phase, we sought proposals that focused on projects that would promote ways to implement successful evidence-based strategies and practices. And this is the second in a series of 6 webinars that will describe the 2010 series, all of which are focused on dissemination. Today, you'll learn about dissemination and implementation of evidence-based methods to measure and improve pain outcomes. Then on your screen, fortunately I don't have to read it, you can see the preview of coming attractions. You'll obviously want to write that in your book. And you can get more details on these sessions at the web address www.inqri.org, and you can view previous sessions. As there's a little bit of a picture to kind of describe what the goals and the operation of INQRI have been. It has a strategic focus on supporting interdisciplinary teams that propose diverse, innovative research initiatives, roughly speaking, with the similar goal of design to establish the link between nursing and high quality in patient care. We're important to emphasize it's not just nursing quality, it's quality of all care that's important. The premise is that interdisciplinary collaboration is important for rigorous science. And so we've supported research teams that did apply diverse perspectives and methodological techniques to answer questions without sacrificing the relevance and insights provided by clinicians. The interprofessional approach was extended also to the group of stakeholders selected to advise the INQRI grantees and program leaders by involving key stakeholders in the conduct of the research from the outset. We hope to build, and I think we did build, strong partnerships with potential end users of the research function. So I'd like to acknowledge collectively the guidance provided by the select group by a subset of these stakeholders, our National Advisory Committee. These committee members have supported not only our researchers, but also the program leaders and offered us a lot of wise and prudent advice over the years. They've been asked to review proposals, advise grantees on their project plans, lead discussions on project findings during our annual meetings, and much more. So one of the most prominent members of our National Advisory Council is joining us today. That's Shelley White-Means, and in a minute she will introduce you to Nancy Dutton, Susan Beck, and their work on improving pain outcomes. In the meantime, it's my honor to tell you a little bit about Shelley. She is a professor and director of the Consortium for Health Education, Economic Empowerment, and Research at the University of Tennessee Health Science Center. She's past president of the National Economic Association, a postdoctoral fellow of the Gerontological Society of America, a member of the National Academy of Social Insurance, and on the steering committee for the Meharry Medical College Community Health Center's Community Networks program. Shelley earned her bachelor's degree in economics from Grinnell College and her master's and doctoral degrees from Northwestern University when I was pleased to be introduced to her. Prior to her current appointment at the University of Tennessee, she was on faculty at Cornell and at the University of Memphis. Shelley's own research emphasizes the social determinants of health disparities, racial, ethnic disparities faced by blacks and Hispanics in the utilization of medical services, and labor market implications and costs of family caregiving. Recent studies have documented the distinction between racial and ethnic differences and racial and ethnic disparities in healthcare utilization. Not all differences are disparities, and vice versa, and also how labor market disparities are associated with health insurance disparities. So Shelley has been an extraordinarily active and helpful member of our National Advisory Committee since the beginning, which now seems a long time ago, but we thank her for her service and for leading her session today. Shelley, I'm going to turn it over to you.
Thank you so much, Mark. It is my pleasure to introduce our INQRI study project today. The emphasis of this project is on a critical area of patient satisfaction and quality care. That is, whether or not pain is experienced and relieved during patient care. The perspective is that nurses can intervene in this process and improve outcomes. The project team disseminated and implemented evidence-based approaches to measure and improve pain care and outcomes in hospitals across the United States. For translation purposes, the team developed a pain care quality toolkit for widespread use in pain management. The study project is dissemination and implementation of evidence-based methods to measure and improve pain outcomes. The interdisciplinary study team is led by Susan Beck and Nancy Dunton, who will share insights about this outstanding project with us on today.
This study was a partnership between the University of Kansas School of Nursing and the University of Utah's College of Nursing and Billings Clinic in Montana. The University of Kansas Medical Center School of Nursing is where the National Database of Nursing Quality Indicators is managed by KU for the American Nurses Association. Dr. Susan Beck, who's an expert on pain care quality, developed the instruments for measuring pain care quality and directed the study. I am a sociologist and was a co-investigator with my experience with data collection from large groups of people. The study had two goals. First was to evaluate the impact of disseminating and implementing pain quality indicators using an audit and feedback process. And the second was to implement and evaluate an innovative translational research program to measure and improve pain care processes and outcomes in a sample of U.S. hospitals. At first, we will discuss the evaluation of disseminating and implementing the pain care indicators. The study had four phases. First, recruitment of hospitals to participate who were members of the National Database of Nursing Quality Indicators. These hospitals were used to data collection and reporting. Second phase was a data collection phase. Staff nurses administered 16-item survey to participants about pain care quality, and then they received a report back with unit-level data and national comparison data of the other units participating in the study. Interview subjects were patients who were over 18, could speak and understand English, and would have been on the unit for at least 24 hours and either experiencing pain or having received pain care, having received pain medication. The third phase of the study was the interventional phase, with units who had at least 5 patients assessed in April and who scored in the lowest third on unit average pain score and the lowest half on one of 3 quality indicators. They were randomized into 3 groups for 3 interventions intensities, and then data was collected again in November 2011 so that we could examine any change that had occurred. One of the important parts of collecting data from a large sample of hospitals is training the nurses to do the data collection. So the staff nurses receive training via online training modules and video simulation. They were given a packet with IRB materials that they could use to adapt to their setting for their IRBs. We gave them standardized data collection forms for when they did the interviews, and then data were entered into a customized Excel spreadsheets with validations to help from avoiding data entry mistakes. Finally, 2 dedicated staff members at INQRI were available to answer questions about the data collection process and for assisting people with understanding the materials they've received. Overall, we had anticipating getting about 100 hospitals to participate in the study, but there was very great interest in this topic naturally. So about 400 hospitals said they would apply, but within about the 6-week window that we had, 326 of them completed their IRB process in time for data collection. So the overall sample was 326 hospitals in April. We had some attrition, and so there were only 253 hospitals in November. These things happen naturally. People get busy. The Joint Commission comes to visit. There's staff turnover, and the original person's no longer there, etc. Since the analysis was done at the unit level, our actual analytic sample size was 1,577 units in April, 1,191 in November. We assessed over 12,000 patients, the nurses assessed over 12,000 patients in April and just under 9,000 patients in November. The average number of patients assessed per unit was 7, and about 82% of the patients who were eligible for taking part in the survey agreed to participate. So we had a rather large sample size. The outcomes of the April data collection were, on average, during the past 24 hours, pain was rated by, on a scale of 1 to 10, pain was rated by the patients at 6.02 on average. And 94% had received pain medication. For those receiving treatment, the average percent relief was quite high, 71%, although certainly there were still 30% of the patients that were having unrelieved pain. And 28% of the patients were in severe pain frequently or constantly. 89 to 90% of the patients agreed that they had pain medication available when they needed it. So the findings were rather mixed. The outcomes from the November survey were basically identical in terms of the percentages on these questions. This graph shows shows 6 questions from the survey. My nurse believed my report about pain. I had pain medication available when I needed it. In addition to medications, my nurse suggested approaches to help manage my pain. My nurse discussed side effects of pain with me, or pain medicine. Pain medications worked well to control my pain. And question 6, my healthcare team involved me in discussions about controlling my pain. The blue bars represent those that said, the blue portions of the bars on these questions represent the patients that said strongly or moderately agreed. Red was slightly disagreed or slightly agreed, and green was slightly disagreed. You can see that there are very high percentages of patients on agreeing and or strongly agreeing with these questions, except for the nurse suggesting alternative approaches to help manage pain, and my nurse discussed side effects with me. From the results, we also determined that different patients had different risk of pain, had higher odds of being in pain. In particular, African Americans and American Indians were at higher odds of having pain and unrelieved pain. women were at greater risk of having pain and unrelieved pain. Medical patients rather than surgical patients were at had higher odds of having pain. Also, patients who had chronic pain were more likely to be in pain than those with other types of pain. And then medical, surgical, and step-down units had patients with higher rates of pain than did obstetrics or rehab. At the end of the data collection, we raised the following questions in the team. We know that the measurement of pain care quality is complex. It is a nursing-sensitive indicator in that nurses are the front line of involvement in treating patients' pain, but they exist within a multidisciplinary team surrounding the patient. We ask ourselves questions about, did we choose the right indicators, because there were other questions that Dr. Beck had developed in her previous INQURI study. The time to interview patients is a potential barrier to adopting this pain care quality measurement into routine data collection for national databases. And we had a little hints of inconsistencies in data collection. They weren't large, but they did have to do with gaining consent and getting the correct patient eligibility and coding race, because sometimes the nurses clearly said that they looked at the patient, decided what race the patient was, and coded it rather than asking the patient. So also getting multiple IRB approvals, the 356 IRB approvals, was a challenge. And we're left with a discussion about how to sustain pain care quality measurement so that it becomes a nationally used indicator for as part of patient care quality. I'll now turn the presentation over to Dr. Susie Beck.
I'm very pleased to be with you today to share with you the results of our INQURI project, and thanks to Nancy for talking about our first study goal, and I'm going to pick up and tell you about what we learned from our second aim, which was more focused on implementation, and we tried to evaluate it, sort of an innovative approach, try to improve pain care processes and outcomes in a subset of this sample of U.S. hospitals that participated in the first data collection. If you look here at the intervention phase, from the 1,611 units, identified units who had more than 5 patients who were assessed. We felt like if there was less than that, the credibility of the data might be questioned, and who were in the lower third on the unit average pain score and the lower half on one of 3 quality indicators. So we tried to identify units who really had a need to improve. And they were recruited into the study and then randomized into 3 groups. The 3 groups included what you might consider sort of a usual practice condition, with one exception. So normally in INQRI, units participate, submit their data, they get a comparison report, so we actually replicated that process. However, we asked them to set up a quality improvement team, which one would hope was part of usual practice, but probably occurs some of the time and not all the time. In level 2, we asked them to set up that team, but we provided them with an online toolkit, which we call the Pain Care Quality Toolkit. I'll tell you a little bit more about that, to help them with resources both for quality improvement and for ways to improve pain practices. And in level 3, they received the toolkit, and the nurse leaders from each unit, so each unit identified a leader to lead their quality improvement team, participated in a community of practice. And I'm going to tell you a little bit more about that, but the idea was that they would be able to share and learn from other units who were participating in the project and hopefully improve their own efforts based on what they learned from others. This is a consort or participant flow sheet from our study. There were 206 units who met our eligibility, and 58 of those declined to participate. And so the 148 units were randomized by hospital into the 3 levels of intervention. And we did it by hospital because we were concerned that if one unit in the hospital got the toolkit and the other one didn't, the other one would probably get access to it as well. And so it made more sense to really structure it as a within hospital design. We did have, you'll notice in the follow-up section, 9 units who withdrew for varying reasons, including the unit being closed in a couple of areas, or the leader left, or they just lost contact. They weren't replying to any of our correspondence. This is an example from our Pain Care Quality Toolkit. So it is a internet-based toolkit and was really structured to provide sort of a step-by-step approach to forming a QI team, how to really focus and set goals, and then to plan a rapid cycle change. And then within the planning part, we provided a whole lot of tools related to managing pain that they could use for education purposes. Some were organizational type interventions, patient education materials, etc. These are some of the kinds of things. So we learned from our advisory group within INQRI that one way information was really transmitted was doing huddles at the beginning or end of a shift. And so we made huddle sheets, sort of one-pagers, that would cover a specific amount of information. We had both short, like a 10-minute, and a long 45-minute lecture on various topics. We had examples of SBAR communication, clinical practice guidelines. We had a whole section on pain in special populations, including patients with abuse issues, elderly, patients who had cancer pain. There was a section of patient education materials, and then a tool share in which we invited the high-performing units from the April data collection to submit to us tools that they thought helped them to excel at managing pain. And we got, I believe, about 26 submissions that are included in that. They included things from policy to specific approaches they might have used for education on their unit. This is just an example of one huddle sheet that addressed fears about addiction and had some specific information about how to recognize addiction and then what to do if they were concerned about how to manage pain in a patient who had a substance abuse problem. We used Google Analytics to monitor how the toolkit was utilized during the course of the study. We had over 300 and some individual users, which there were 96 possible hospitals, so usually more than one user per hospital, almost 10 pages per visit. And you can see they actually, this is during the whole course of the implementation, there's a bump in the use, initially, but in fact, people went back to the toolkit through the whole course of the study. In the communities of practice, we really learned a lot, I think, about the kinds of issues that the units were dealing with. We had 8 units assigned to each community of practice, and they had a monthly phone call in which they would be asked to give an update. And so they felt the updates really helped them sort of keep on target with the project because they felt a responsibility to report. We also used a listserv, which wasn't well adopted by nurses. Staff nurses just really didn't have time to participate in that. They would send information to the community of practice leader, and we would sort of turn around and put it back out on the listserv. So we tried to use it that way, but that strategy actually wasn't very successful. Just to give you a few examples of the kinds of strategies that the communities of practice shared, one orthopedic unit developed a whole campaign around being on target, and they used a bullseye, and the target being trying to help the patient establish their targeted level for pain, and as a unit to reach their targeted goal for the project. Another unit felt their issue was really a lot about the attitudes of the nurses. So they decided to use humor as a way to approach it, and they developed a skit and had the nursing staff participate in giving this skit at a staff meeting to sort of try to unfreeze some of the attitudes and begin to have a serious conversation about how those attitudes were impeding them. And we certainly have many more examples. In order to analyze the data from this study, we actually did a multi-level analysis because the units were nested within hospitals. But this is a graphical depiction of the average pain score means from pre to post. And the three lines that are parallel are our three intervention groups. So the results showed that all groups significantly improved over time, and there wasn't a significant difference by adding either the toolkit or the toolkit and the community of practice. However, we then compared those three groups to the lighter line, which is the flat line that you see, and that's the other 927 units who were not randomized, who just participated in the audit and feedback data collection component. And as Nancy mentioned, there was no movement in the overall group. So all the units who participated in the improvement effort significantly improved as compared to the non-participating units. So what did we learn about improving pain care quality? Well, first of all, I think we really learned it was complex, both in terms of the complexity of the issues that the nurses were dealing with. The fact that many nurses who agreed to be leaders in this didn't have a lot of experience in leading improvement efforts. That was really a variable feature. And the types of issues, the places where they decided to focus really varied. So some really, felt from their data that they had an issue with teaching about side effects. And one unit, for example, devised a special patient education tool just about side effects of medications. Where others felt maybe their issue was about transitions in care, so they would get patients from other units and the pain wouldn't be managed, or the pain got out of control in the interim, for example. So there were so many different ways that they worked on improving pain. So I feel like one of the things we accomplished is we really created sort of a whole national campaign about pain improvement that led to lots of different innovative ideas. Are our measures good? Well, certainly the pain on average measure, which is a fairly standard outcome, was sensitive. But in terms of the pain care quality, it was really the only one that improved over time was the efficacy of the pain management, of the pain medication. And I think this is a big issue because pain medication may not be prescribed in a strong enough dose or frequently enough. And that's really one of the reasons why there's so much unrelieved pain. When we look at this national picture, which, by the way, is really the first national picture like this, as I've looked at other studies, there are lots of small sample or a couple hospitals, but nothing of this scope. I think both the toolkit and the community of practice were well received. The nurses really liked them. Clearly they used them. But it doesn't seem that they necessarily added to an improved outcome, at least within the time frame that we had for this study. I wanted to just talk a little bit about, since we ended the study, we made the toolkit available to all INQRI hospitals through their website. So it's not publicly available. That's our next step, but we wanted to first make it available within INQRI. And we've had a very good uptake, 591 visits since May 1st, and that's from hospitals or units from 43 states. So national interest as well. In Texas, they're really the hot place to go. They're our greatest uptake place, although we did have a lot of hospitals participate from Texas. That might be part of it. I want to end with some practice and policy implications. So clearly the important ingredient really is this commitment to engage in a systematic improvement effort, and there are then many ways to get there. I think the toolkit and community of practice helped, at least by the reports that we got and the ways that nurses use them, but certainly the usual practice units also found the resources to improve their pain. I believe we need to find a way to build pain into the set of standard measures related to the quality of care. And because of the 18-month nature of our project, there really was only 4 to 6 months in that improvement phase, which may not be long enough to really make the kind of improvement, because even the units that improved, they went from 7 to 6. I'm just rounding. They improved almost by a whole point on the 0 to 10 scale on average, but still there was a significant amount of unrelieved pain on those units. And finally, in terms of policy, in the course of doing this project, pain has become a very political topic. If you read the New York Times, we have these competing epidemics of chronic pain. The New Institute of Medicine report out on that, with this whole issue of abuse of prescription medications. I think that dialogue or discourse has influenced attitudes and beliefs among patients, family members, and providers, which are creating more barriers to effective pain control. There now have been regulatory efforts. I don't know if you read in I think it was 2 weeks ago, the mayor of New York City is proposing legislation to limit access to opioid analgesics in emergency rooms, which seems to be a pretty strong response, and which I believe will have a lot of untoward consequences. And then finally, several legislators have gotten involved in investigating the role of the pharmaceutical industry and how it has influenced pain practice guidelines. As a result of that, the American Pain Foundation shut down almost overnight, and that group was one of the main pain advocacy groups in the country. So I believe this data and this project fits into a broader context that will lead to lots of interesting discussion. We would, of course, appreciate your opinions about that. In closing, I want to thank all the members of our interdisciplinary team. And this is a photo we took at the INQRI meeting in April, including Dr. Pat Berry and Janine Branch, who are co-investigators, Susan Tavernier, my postdoctoral fellow, and Jackie Eaton, Joanne Guao, who are doctoral students, and Katima Potter and Beth Spornitz, who's not in our picture, who are from the INQRI staff, and without whom this project would not be, I can tell you that. So, and then we also want to acknowledge all of our partner organizations, and especially thank the Robert Wood Johnson Foundation and INQRI for the funding and support to do this project.
Wonderful. Thank you so much, Susie and Nancy. Shelley, I think we're ready to turn it back over to you.
Yes, I also want to echo a thank you to Nancy and Susan for sharing your insights about this tremendous and successful effort to improve pain care. We're now going to begin our question and answer period, and I want to start with a couple of questions and then open it up to the audience for participation. My first question pertains to some of your initial findings in your assessment of pain management, which were very interesting. I think it was slide number 10. The data indicated that 2 areas for additional nursing emphasis were in advising about alternatives to medications for pain management and discussion of medication side effects. I'm curious as to how or either your toolkit or your community of practice efforts were directed toward in improving nursing efforts in this area.
Okay, I think this is Dr. Beck. I think that question's probably best for me. So when we designed the toolkit, we actually took each of the indicators and tried to develop specific components of the toolkit that would be relevant. So, for example, the whole issue of believing might be influenced by fear of addiction, which is one of the things that I showed you from the toolkit. We also had a huddle sheet and a mini and long lecture on non-pharmacologic approaches to pain management, and we had a whole section on pharmacologic management, which included side effects. And we also had a patient education guide that had side effects, information about side effects for patients. So, and then, for example, like involving the patient in decisions, we developed a tool that could be used to help involve the patients in decisions about their care. One exemplar to share there is one unit, which then I think got adopted by some others, used the whiteboard approach, which is, of course, common in hospitals now, but added a part on the whiteboard that said, what is your target pain goal, and then what is your pain now, and when is your next pain medication due, as a way to improve the communication and involvement with the patient about where they were trying to get with pain relief. And quite a few units who learned about that intervention were excited that that might be something they could try.
Your intervention impact showed that your intervention was successful. And it also showed that it didn't, there were insignificant differences between whether there was the use of the toolkit alone or the use of the toolkit plus the community of practice. Could you share why there might not be differences in the impact of those two types of interventions?
Well, this is Nancy. I think I'll begin, but Susie will want to add to this. One of the key things we think is important in explaining these results are that the intervention was limited due to time constraints with the grant, so that it was 4 to 6 months in duration, and it may be longer. A longer intervention phase would produce more variability in how effective each of the results were. I think that it's important for one thing, it's important to know that there was some slight improvement with the control group, basically, but at the end of the intervention period, all 3 interventional groups were very close to the level of the control group in terms of pain level. And so that, one of the messages could be that focus and attention to the problem, no matter what the intervention, is effective, just bringing staff engagement to the problem of pain care quality.
Regarding the IRB, you mentioned, I think, more than 300 IRB approvals. Can you provide some tips for researchers on how to best manage such a large number of IRBs?
Yes, thanks. We have found that making our IRB materials that we use inside the University of Kansas available to hospitals as guidelines for the forms they have to fill out in their facilities is extremely helpful. Second, having a point person who understands the guidelines of the IRB in their facility is a helpful thing. We did lose facilities, and we did lose a few facilities because they couldn't manage to get through their IRB in a 6-week period. So one of the additional things you can do with a study is allow more time, at least 2 months or 3, if you have the time, to get through the IRB process. But giving them a jumping off point with your own materials is a very useful thing. And we had Beth calling them and saying, how's it going? What are you doing? How can I help you? So we provided a high level of technical assistance in getting them done. I would say that not every hospital has an IRB, and that some hospitals view this as a quality improvement activity and not a research activity. And so that varies all over the map. But we did ask chief nurses in hospitals that weren't going to go through their IRB or didn't have an IRB to acknowledge through an email, some kind of communication that the study had their permission in the absence of an IRB review.
Great, thank you. Regarding the toolkit, actually, is that being made publicly available, or is that just for the sites in your study?
No, it's going to be publicly available. There's some changes that Dr. Beck and her team want to make to it as a result of the review that the participants provided on the toolkit. So once those changes are made, it will be posted on the INQRI website in a publicly available space. So that's forthcoming.
Great.
One of the things that I found pretty interesting about this study that we did not talk about today was we saw the data on that there was a fairly high level of unrelieved pain, that patients said that they got good relief from pain medications, except for 30% of them, there were questions about how satisfied they were with pain care management in their unit, and their satisfaction levels were quite high. So I think one of the conversations that pain experts need to engage in is what are the expected levels of pain care management, and are patients sort of happy with anything because they have such great fear of pain to begin with. And so the fact that there was attention being paid by nurses in assisting with pain control made them very happy, even if they were still in pain. Shall we go back to the question about pain care toolkit? Would you like to restate the question, because I only covered part of it?
I'm sure that's a good idea. Shelley, could you repeat your question on that one?
Yes, the question was about the difference in the, let me go back. The question was about the lack of difference between the improvement in outcomes when the toolkit alone was used or the toolkit plus the communities of science, even though both improved outcomes.
So I wish I knew more about that. We are analyzing our qualitative data, so we interviewed all the nurses at the end of the study to see if we can try to sort out, were there differences in or similarities maybe in the ways that the unit approached it. But I would say that people were, even though they were chosen because they had a need to improve, they were really excited about being part of this study. I think Nancy could validate that. Maybe she said that. And so I think that just that, generating that energy and sort of stimulating that improvement process is one of the key ingredients. I think that's a lesson for implementation science. And so the other things maybe are nice to have, and certainly I hope that we can continue to make, especially the toolkit, available, but they may not be necessary.
I would add to that, though, that I would say that it would be beneficial to have the toolkit available, because there's a difference between achieving an improvement in a 6-month period or less and achieving sustained improvement, and I think additional resources are helpful after you get past the initial enthusiasm.
That's a good point. But I appreciate other people's ideas about this there.
There are a couple of questions. Go ahead, I'm sorry.
I have a question that just came in, and I might misstate it, so if I do, Jackie Dello, I'm sorry. It says, how do I find the site where the various units with which interventions are specific to their results, or is this data lumped together in the slides with the SWOT lines?
So we did not present the individual unit data. That would have been a lot of data with 148 units. So the data are actually with the whole, because we have about 900 and some as well. So the data are presented in aggregate.
I don't. This is Nancy. I think that there will be publications about the units. I'm not sure we described the units, which were medical, surgical, combined med-surg, obstetrics, and something else. Can't remember.
Rehab.
Rehab. But we didn't distinguish analytically so far much between them in terms of what units used which interventions, and that may have come about from some of the qualitative data that you collected, Susie, but I don't think we captured it numerically.
Right. So what we're trying to do is to categorize the data about what targets the units had, and also what particular types of interventions that they used, and whether or not they used the toolkit or not. So we do have all of that information, but we're in the process now of, we've got all the baseline interviews analyzed, of sorting that component out. And yes, of course, that will be something we can hopefully add into our publications.
Great, very good. Do you have plans? Do you have plans for the publication, Nancy? The publication ideas that you mentioned?
Yes, Susie may be able to speak to this better than I can. I do know that that there are several publications planned for the different aspects of this project. We've done some work just in terms of how to, posters basically, on how to carry off something like this kind of endeavor. And then Susie's team has more variety of publications and presentations in the queue.
Yeah, so we've really focused this past year on dissemination through different types of professional meetings, including at the ANC Magnet Conference, where we got, I think, probably our biggest audience of over 600 nurses and a very good response. We also had, of course, posters at the INQRI National Meeting, and we'll be presenting next week, actually, at the ANA Nursing Quality meeting about our work. And then we're hoping to publish the main findings regarding sort of this national snapshot of pain care quality in a major medical journal. I'm going to submit it to the New England Journal first, partly because as I've sort of working on the paper, I've realized that there really has not been any kind of big picture look like this. And then we just submitted the second phase findings to Academy Health, to abstracts, and we were talking about possibly publishing that in Implementation Science, but we haven't made a final decision about that. And then my postdoctoral fellow is working on the poster turning the poster she did at INQRI about our sort of large-scale qualitative analysis into a paper. And she also submitted an abstract to Academy Health with that. That's where we are, right?
At INQRI at KU, we are planning on combining the data from this study with data on the characteristics of the nursing workforce on each of these units and hospital characteristics to examine differences in, if there are differences in the among factors that produce or that could be related to the different outcomes. So we've just barely begun to look at that, to look at staffing variables relative to the pain care levels and the other measures of pain care quality.
Thank you. We have a couple more that have come in. The first one is, can you comment on the potential differences in characteristics of units or hospitals that chose to participate versus those that did not?
I don't think we looked at
in which phase, I guess.
Okay, Katima, who's listening, just sent me an IM that said that the units that participated had the same composition as NDNQI on teaching status, such as are the hospitals academic medical centers, teaching hospitals or non-teaching hospitals, and whether they were magnet or not. So the sample represented the INQRI sample. The INQRI sample is different than the national sample because it's overrepresented with larger hospitals. But we can look at more detail for the publications in terms of if the dropouts from the study were of some particular type. But I think overall we had, at least at the first level look, no differences in terms of dropouts and participants.
Great, thank you.
And then the second phase group was definitely different intentionally in that we used those criteria to select the low performers. That does raise the question of whether we had some regression toward the mean, or, as Nancy said, perhaps what we really had is a Hawthorne effect because all these units were excited about it participating and wanted to improve.
Great, thank you. On another front, I think that the contextual issues that you've outlined are very important. Can you comment on the recent panel recommendation to the FDC that nurse practitioners should not be able to prescribe certain pain med categories?
So this is Susan Beck, and yes, actually I was just reading about the FDA. The FDA now is potentially also going to impose greater regulations on the use of opioids, and one of the things in that in those hearings and that has been brought up is exactly this issue of restricting the ability of nurse practitioners to order scheduled medications, which, of course, again, is exactly the wrong way to go. We want nurse practitioners to function to the full scope of practice, as is recommended by the Institute of Medicine report on the future of nursing. And I think, this is an important issue that all of nursing should be watching and should be advocating against such types of restrictions.
Quite a few comments just favorable and thanking you for this presentation. And it looks like I have one last question. How did the evidence you develop on effectiveness affect the dissemination process? Would hospitals have been as interested in the toolkit even without evidence?
This is Nancy. I don't know that we have any quantitative data on this, but given the level of interest in among the hospitals in pain as a topic, I think that the toolkit will be widely used.
And certainly we used an evidence-based approach in developing the toolkit and referencing clinical practice guidelines, where appropriate, and other sources when we utilized references that were perhaps not included in a guideline but were best practice types of evidence.
I think it also depends upon how we set up the toolkit on the public space. We have a pressure ulcer educational tool tutorial on the public space that offers one CE for doing the tutorial, and we've had it for a number of years out there, but the number of people who have gotten that CE from the tutorial, the pressure ulcer tutorial, is way over several 100,000. And so I think if we can set up the pain care toolkit with a CE, it will attract people to that.
A good idea.
Without any evidence of effectiveness.
Yeah.
Great, thank you. I just have a couple more positive comments, and thank you. Thank yous that have come in, and I will echo those thank yous. And also just want to let all of the participants know that we thank you for your participation today and for all of your questions. The final version of this video will be made available by Monday morning at our website, www.inqri.org, and will be housed on INQRI's YouTube channel, so you can view it at any time and also forward it to your colleagues. And please join us for our future sessions. As Mark mentioned at the beginning, we have quite a few still left in our queue, and those registration sites will be available also on our website. So thank you for that. Also, I just want to thank our presenters as well as Dr. Whitemeans for serving as our moderator, and all of our inquiry leaders who have joined us, Mary Naylor, Mark Pauley, and Lori Malakar. Thank you all for joining us today.